Welcome back, smartnesses. So today we are going to tackle some questions in IRIH. Mrs. Nyaniwe Piri Gravida 1 Para 3 has been brought to the hospital. Upon examination, the patient complains of severe headache, epigastria pain, and blurred vision. The patient has been diagnosed with pre-eclampsia. A. Define pre-eclampsia, 5 marks. So, pre-eclampsia can be defined as just a complication in pregnancy which occurs when gestation age is greater than 20 weeks and the woman presents with a blood pressure of more than 140/90, protein in urine with or without edema. Then you get your full 5 marks. Okay. State 5 signs and symptoms of pre-eclampsia. So when they say state, you don't only write a sign or symptom, but you also say something about that sign and symptom for you to get the entire 10 marks. Okay, so the 5 signs and symptoms that we can mention here, we can talk of hypertension. So hypertension is due to generalized vasoconstriction that is brought about by the release of oxidates as the result of starving the placenta when there is reduction of blood flow. So that's how hypertension comes in. Another sign and symptom that you can talk about here is edema. Now, edema is basically due to endothelial cell dysfunction that results into extravasation of the fluid, leading to edema. Then, number 3, we can talk of proteinuria. So, proteinuria is basically just due to damage of the glomerular filtration mechanism, which is brought about as a result of reduced blood supply reduced blood supply to the kidney. So when the glomerular filtration is damaged, then proteinuria comes about. And the 4th sign and symptom that we can talk about here is oliguria. So the woman is usually presents with urine output of less than 30 mL per hour. This is due to reduced blood flow to the kidney, which is worsened by extravasation. So that's how oliguria is a sign and symptom. It's because the woman, first of all, oliguria is basically a reduced amount of urine. So the woman will be presenting with urine that is less than 30 mL per hour. So the reason for this is because of reduced blood flow to the kidney and also the extravasation of fluid, the one that led to edema. Okay. Then the 5th sign and symptom, we can talk of epigastric pain. So epigastric pain is basically due to severe reduction of blood supply to the liver, and this symptom usually denotes pending eclampsia. Okay, so that's how you can answer these questions here. All right, let's move on. So C is saying outline 5 predisposing factors of pre-eclampsia. Okay, outlining 5 predisposing factors. So even here, you don't only outline, but you also say 1 or 2 things. So the 5 predisposing factors that we can talk about is odd prime gravida. So mostly pre-eclampsia is very common among individuals with who have their first pregnancy at the age of 35 years or above. So these individuals, they tend to have constant levels of estrogen in their bloodstreams, which causes which in most cases brings about vasoconstriction. So old age is a predisposing factor. Another predisposing factor is chronic hypertension. So an individual who has had chronic hypertension before getting pregnant is at high risk of pre-eclampsia or pregnancy superimposed hypertension. The third predisposing factor can be multiple pregnancy. So when a pregnant woman carries 2 or more offsprings, the estrogen levels, they tend to be elevated, and this may cause generalized vasoconstriction, which may result into pre-eclampsia. Then the fourth one, you can talk of, genetics. So this is when preeclampsia may occur as a result of it running in the family. So an individual who is pregnant and there is a history of preeclampsia in the family is at a higher risk of also having preeclampsia. Another predisposing factor that we can talk about here can be a previous preeclampsia. So a pregnant woman who had preeclampsia in her last pregnancies is at higher risk of developing preeclampsia as compared to an individual who had no preeclampsia in a previous pregnancy. So those are the 5 predisposing factors. So we have talked of old age, chronic hypertension, multiple pregnancy, genetics, and also a previous preeclampsia. Then you can also talk about obesity. You can also talk about dystocia dystrophy syndrome. So preeclampsia has been observed to be common among individuals who are short, fat, and who are dark and with dark hair. Also add maybe low socio-economic status. So all those can be predisposing factors. Okay, so let's quickly jump to the next question, of course. All right, so D is saying, describe the management of Mrs. Piri till discharge, 50 marks. So I'm just going to summarize the management so that it doesn't take much of our time. So under management, of course, you start with your aims, the way you always start with your management. Then you can do your history taking, physical examination, you can do your urinalysis, liver function tests, some full blood count can be done. Then when it comes to treatment of preeclampsia, of course, we use anticonvulsants. So that we prevent convulsions in this woman. So the drug that we can use under anticonvulsants is magnesium sulfate. Okay, so a total of 14 grams is given for magnesium sulfate. Never give magnesium sulfate if the respirations are less than 16 breaths per minute, because it can cause respiratory distress. And also remember that you should never give magnesium sulfate if urine output is less than 30 mils per hour. So also don't give that. So remember, when you are giving magnesium sulfate, the loading dose of magnesium sulfate is 20% solution of 4 grams IV slowly over 5 minutes, then followed by 50% solution of 5 grams IM on each buttock. Then the total should be 14 grams. So that's what you do under anticonvulsants. Then you can also give antihypertensives like hydralazine. So you can give hydralazine 5 milligrams IV slowly over 25 to about 30 minutes. Yeah. Then you can also give sedatives. So sedative will only be given if anticonvulsants are not available. Then you can give a sedative like diazepam. So diazepam can be a drug of choice. So with diazepam, the loading dose should be 10 milligrams IV over 2 minutes, slowly. Then a maintenance dose of 20 milligrams in 500 mils of IV fluid, such as Finger's lactate, over 4 hours. Okay, so that can be done. But I would urge you to basically pay attention whenever you are allocated to your words, because right there in the labor word is where you can learn a lot of things, and how to manage these conditions. Okay, so you can also sometimes you can also do induction of labor. So this one is done if the pregnancy is at term. So preeclampsia can be best treated by inducing this labor. So when inducing labor, you can give the drug cytotec. The dose is 20 milligrams sublingually, or it can be inserted into the vagina. Then you can also give oxytocin. You know, cytotec or oxytocin can be given. Okay, so when it comes to the nursing care, you know, always start with M's. Once you put your M's, so your M's maybe can be, for example, you can say to help the woman carry the pregnancy to term in order to deliver a normal live healthy baby. You can also say to prevent maternal complications such as disseminated intravesicular coagulopathy, yeah, the DIC, and any other aims that you can think of. And from there, you follow the eprophenema, start with the environment. Yeah, after you do the environment, then in your environment, make sure you also include the maternal well-being. So under maternal well-being, you should put psychological care. Yes, you should remember to put the psychological care. So maternal well-being should be a heading of its own. So after you start environment, then you write a title saying maternal well-being. Then you can start with psychological care. You do your observation, you know, positioning of the mother. You also promote rest. So all those should be under maternal care. Then you also do your nutrition, fetal well-being. So all these I'm giving you should be titles, and you have to be writing something under each title. Yeah. So then under the fetal well-being, you talk about you know, monitoring of the fetus, checking up, and all those things that you talk about there. So that's basically the best summary I can give under management. Okay. Then E is saying explain 5 complications of pre-eclampsia. 5 complications. Okay, so we are explaining. So some of the complications that can come about with pre-eclampsia is what we call HELP syndrome. So this one is a condition which is very common in women with preeclampsia, mainly characterized by hemolysis, as well as elevated liver enzyme and low platelet count, which gives a big danger for disseminated intravesicular coagulation. Then another complication that can come about is the same DIC, disseminated intravesicular coagulation. So uh, here the woman can present with low levels of platelet count, which may cause the woman to bleed severely from all part of the body, and in most cases it leads to even maternal death. Yeah. Then another complication is intrauterine fetal death, of course. So this is a complication which comes as a result of reduced blood supply to the placenta, which may lead to poor oxygen supply to the fetus, and the baby can die. Okay. Then another complication that we can talk about here is intrauterine growth retardation. So this is where the rate of fetal growth is slowed. Then we can also talk about placenta abruption. So this is where a normally situated placenta separates prematurely before birth. We call that placenta abruption. So that can be a complication. Then others that you can add as complications can include placenta previa. It can also include antepartum hemorrhage. and also prematurity, and also just underweight. Yeah, even underweight can be a complication. All right, smartnesses, thank you for attending today's lecture. So for today, we end here.